Hi, welcome to our channel of IGNOU audiobooks. Indira Gandhi National Open University, School of Continuing Education, SOCE, Master's Degree Programs, Master of Science, Food Nutrition, MSCDFSM, Revised Second Year MFN5 Clinical Therapeutic Nutrition Unit-13 Nutritional Management of Metabolic Diseases 2. Gout and Inborn Errors of Metabolism 13.1 Introduction Metabolic diseases, as you already know, refer to those disorders in which the various reactions in the cells are affected, production of energy or utilization of energy, due to abnormal production of one or more hormones, or a deficiency of an enzyme. Most metabolic disorders are genetic, though a few are acquired as a result of diet, toxins, infections, etc. Metabolic disorders or inborn errors of metabolism are inherited traits that result in the absence or reduced activity of a specific enzyme or cofactor. In general, these genetic metabolic disorders are caused by genetic defects that result in missing or improperly constructed enzymes necessary for some step in the metabolic process of the cell. Phenylketonuria, tyrosinemia, maple syrup urine disease, homocystinuria and galactosemia are some common metabolic diseases caused by genetic defects. Gout is yet another metabolic disease caused due to a disturbance of uric acid metabolism occurring chiefly in males, characterized by painful inflammation of the joints, especially of the feet and hands, and arthritic attacks resulting from elevated levels of uric acid in the blood and the deposition of urate crystals around the joints. The condition can become chronic and result in deformity. What is the cause of these metabolic disorders? How to diagnose and prevent them? What is the treatment? These are a few aspects discussed in this unit. Objectives: after studying this unit, you will be able to enumerate the etiological factors and symptoms of gout and few inborn errors of metabolism, describe the metabolic changes in these disease conditions and the complications, diagnose the conditions, discuss management of the diseases, and provide guidelines for diet counseling, prevention and control. 13.2 Gout. Gout is a chronic disease due to an inherited abnormality of purine metabolism. What are purines? You may recall studying about purines and their metabolism in Unit 8, subsection 8.3.3, in the Nutritional Biochemistry course, MFN002. Purine is a nitrogenous base found in the nucleotides for the synthesis of DNA and RNA. Let us now understand the role of purines and protein in precipitating the metabolic disorder gout. 13.2.1 Role of protein and purine. Cellular materials of plants, grams and legumes and animal glandular organ meats, liver, pancreas, brain, kidneys, contain nucleoproteins. The nucleoproteins are digested and converted to purines, which are finally oxidized to uric acid. The steps involved in degradation of purine to uric acid are diagrammatically presented in Figure 13.1. Uric acid, therefore, is a substance that results from the breakdown of purines, which are part of all human tissue and are found in many foods. You may also recall studying that the body can also synthesize proteins from carbon and nitrogen compounds, acetic acid, glycine, from carbohydrates, protein or fat, and give rise to uric acid. Proteins. Nucleoproteins. Digestion by pancreatic juice. Nucleic acid and proteins. Degradation. Purines. Nucleotides. Oxidation. Enzymatic breakdown. Uric acid hypoxanthine. Xanthine. Xanthine oxidase. Uric acid. It is important to understand that uric acid is normally excreted in the urine. However, excess of uric acid produced by the body from protein we eat and or internal, cellular or N2 utilization can increase the uric acid levels of the blood. The range of uric acid is 2 to 7 mg/100 ml. If the level of uric acid in our body is above 7 mg/100 ml, we have a risk of developing the disorder called gout. In severe gout, The levels of uric acid may go up to 20 mg/100 milliliters. Normally, uric acid is dissolved in the blood and passed through the kidneys into the urine, where it is eliminated. If the body increases its production of uric acid, or if the kidneys do not eliminate enough uric acid from the body, levels of it build up in the blood, resulting in a condition called hyperuricemia. Hyperuricemia also may result when a person eats too many high purine foods, such as liver, dried beans and peas, and gravies. Hyperuricemia is not a disease and by itself is not dangerous. However, if excess uric acid crystals form because of hyperuricemia, gout can develop. The excess crystals build up in the joint spaces, causing inflammation. Deposits of uric acid can appear as lumps under the skin around the joints and at the rim of the ear. In addition, uric acid crystals can collect in the kidneys and cause kidney stones. Having understood the role of purines in the development of gout, let us next review its etiology. 13.2.2 Etiology. Who is likely to develop gout? What are the risk factors? Let us find out. Gout is caused when there is overproduction of uric acid in normal purine metabolism in the body. In fact, a number of risk factors are related to the development of hyperuricemia and gout. These factors include hereditary. Genetics may play a role in determining a person's risk, since up to 18% of people with gout have a family history of the disease. Gender and age are related to the risk of developing gout. It is more common in men than in women and more common in adults than in children. Being overweight increases the risk of developing hyperuricemia and gout, because there is more tissue available for turnover or breakdown, which leads to excess uric acid production. Drinking too much alcohol can lead to hyperuricemia because it interferes with the removal of uric acid from the body. Eating too many foods rich in purines can cause or aggravate gout in some people. An enzyme defect that interferes with the way the body breaks down purines causes gout in a small number of people, many of whom have a family history of gout. Exposure to lead in the environment can cause gout. The disease predominantly affects males after the age of 35 years. Gout starts suddenly with an arthritic pain in the big toe and may continue up to the leg. Small injury or excessive exertion can precipitate the attack. Sometimes exposure to cold, surgery, minor trauma can trigger the attack. Secondary gout could be due to genetic abnormality of uric acid metabolism. Let us dwell further on the diagnosis and clinical features/complications of gout. 13.2.3 Clinical features and complications. You may be enjoying good health but may suddenly get a severe attack. You wake up in the middle of the night, and your big toe feels as if it is on fire. It is hot, swollen and so tender that even the weight of a blanket on it seems intolerable. These problems could indicate an acute attack of gout characterized by sudden, severe attacks of pain, redness and tenderness in joints. The big toe gets affected mostly, but in chronic conditions, it could be the elbow or the helix, outer fleshy ridge of the ear, can also be the site. The uric acid crystals, called tophi, deposit as urate in the joint, causing swelling and tenderness of the joint with severe pain. Figure 13.2 illustrates the uric acid crystals in the big toe. Presence of uric acid crystals in the joint fluid, therefore, is an important diagnostic test for the disease. The doctor will take a sample of the joint fluid and look for the presence of uric acid crystals. Gout is also easily identifiable through a physical examination. The skin is tense, red and shiny and may be associated with fever, anorexia, lack of appetite and malaise. Unwell feeling. The main complication of chronic gout is, however, chronic renal failure. That is a big problem. So, what can we do to prevent and treat this metabolic disorder? Let us read the next section and find out. 13.2.4 Management of gout. The goals of therapy or management of gout is based on the following aspects: early resolution of inflammation, prevention of recurrent attacks, reversal of complications arising from deposition of urate crystals in joints, kidneys, and maintaining ideal body weight. To help meet these goals, the treatment is based on drug and diet therapy. Let us consider these one by one. Dietary management treatment for gout often include a diet of lower purine intake. Indeed, about 1/3 of the body's uric acid can be attributed to diet. Changing the diet to foods with lower purines can help relieve the symptoms, as well as address the actual problem of hyperuricemia, elevated levels of uric acid in the blood. Since diet is an important factor, exclusion of foods extremely high in purines may be helpful. All meats, fish, poultry contain moderate to high amounts of purine, and pulses and lentils need to be avoided. Some vegetables contain low to moderate amounts of purine. Efforts to greatly restrict these foods are generally unnecessary because of their insignificant effect as compared to medications. In fact, drugs are so effective in lowering the serum urate concentration that rigid restriction of dietary purines is rarely necessary. When purine is restricted, as in case of severe gout, it should be restricted to 100 to 150 mg/day. Some high and low sources of purines are listed in Table 13.1. This list can serve as a handy guide for the patients in selection of food items. List of foods permitted and to be excluded from the diet of a gout patient are summarized in Table 13.2. The thumb rule for dietary management is to advise the patient to try to cut down or avoid red meats, organ meats such as brains, kidneys, liver and heart, shellfish such as mussels, oysters, sea eggs etc., peas and beans, alcohol, especially beer and wine. Table 13.1. Dietary recommendations for gout: avoid foods highest in purines, 150 to 825 mg, 100 grams, brain, kidney, liver, gravies, herring, sardines, broth, meat extracts, minced meat, sweet breads. Limit foods containing moderate amount of purines, 50-150 mg/100 grams, whole grain bread or cereals, cauliflower, spinach, fresh saltwater fish, legumes, beans, peas and lentils, meat soups and broth, mushrooms, asparagus, oatmeal, chicken, spinach, wheat germ and bran. Consume foods lowest in purines, 0 to 50 mg, 100 grams, beverages, coffee, tea and soda, refined cereals, cheese, eggs, fat, fruits and fruit juices, milk, nuts, sugar syrup, vegetable cream soups, macaroni/noodles. Table 13.2. Food items for a patient with a gout permitted: refined cereals and cereal products, cornflakes, white bread, pasta, flour, arrowroot, sago, tapioca and cakes, milk products and eggs, lettuce, tomatoes and green vegetables, vegetables and cream soups made from vegetables, sugar and sweets, gelatin, butter, polyunsaturated margarine, and fats of any kind, fruit, nuts, peanut butter, beverages, water, fruit juice, cordials, carbonated drinks, tea, coffee and cocoa excluded. Beans, peas, lentils, spinach, oatmeal, asparagus, cauliflower, mushrooms, fish, seafood, meats, poultry or other flesh, meat extract, gravies, marmite, liver, kidney, yeast and beer products. Beer alcohol intake of fluids should be encouraged to assist with the excretion of uric acid and to minimize the possibility of renal calculi formation. Fluid intake equals 3 liters/day is desirable for all gouty patients, especially for those who chronically pass uric acid or have calcium oxalate renal calculi. Because urate excretion tends to be reduced by fats and enhanced by carbohydrates, the diet should be relatively high in carbohydrates, providing 50% to 55% of calories, and low in fat, 30% of calories. modified in cholesterol, 300 mg/day, and protein intake should be moderate. Further, since being overweight increases the risk of hyperuricemia, patients should be encouraged to lose weight during a quiescent phase of the disease. Finally, avoidance of alcohol should be recommended. The nutritional care summary and a sample menu for gout patients is presented next. Nutritional care summary: advise the patient to maintain ideal weight, avoid high purine content foods, take moderate protein, use low-fat dairy products, eggs and cheese, take liberal carbohydrates, refined cereals, beverages, fruits and fruit juices, vegetables. Take a low-fat diet. Restrict/eliminate alcohol. Take liberal amounts of fluid. Sample menu for a patient with gout: breakfast cereal, bread/toast with butter and fat/jam, tea/coffee, mid-morning tea/coffee, biscuits, lunch shepherd's pie with gravy, parsley, potatoes, steamed green beans, bread and butter pudding, mid-afternoon tea/coffee, biscuits, dinner, smoked haddock with egg sauce, mashed potatoes, shredded cabbage, tomato and cucumber salad, pudding, vegetarian diet, breakfast cereal, toast/khakra/dosa, tea/coffee, tea/coffee, cream, crackers, chopped tea/rice, tomato, paneer curry, aloo methi, butter, tea/coffee, biscuits, vegetable pulav, kadhi, spinach pakodi, salad, cucumber and tomato. Kheer diet is an auxiliary measure to medications. Next, let us review the drug management for gout patients. Drug management: drugs are so effective in lowering the serum urate concentration that rigid restriction of dietary purines is rarely necessary. Uricosuric drugs are used to increase uric acid excretion. Allopurinol inhibits the action of enzymes and the inoxidase, which then produces less uric acid. These drugs must be taken close to the meals, as prolonged use could damage the intestinal mucosa, resulting in reduced absorption of several nutrients and large quantities of water. The person will lose weight gradually and must avoid excessive intake of alcohol. Next, in this unit we shall learn about the inborn errors of metabolism, which you may recall reading earlier in this unit, are inherited traits that result in the absence or reduced activity of a specific enzyme or a cofactor. 13.3 Inborn errors of metabolism. We are now going to learn about some of the disorders caused by inborn error of metabolism, namely phenylketonuria, tyrosinemia, maple syrup urine disease, homocystinuria and galactosemia. You may recall studying about these metabolic disorders earlier in your Nutritional Biochemistry course, MFN002, in Unit 12. We hope you remember the information presented there. If not, we suggest you look up this unit now and read the information given there along with the matter presented here in this section. This will help you consolidate your understanding on this important topic. An inborn error of metabolism is a genetic error that alters the production of a protein. In many cases, the protein is an enzyme. When the enzyme is absent, the functions that depend on that enzyme cannot proceed. Incompletely metabolized products accumulate in the body. This leads to a variety of problems and in many cases it becomes fatal. Further, this imbalance creates problems in other metabolic pathways. That adds to existing problem. The goal of therapy is to prevent the accumulation of toxic metabolites and to replace essential nutrients that are deficient as a result of the defective metabolic pathway. In these metabolic disorders, since there is an inability to metabolize a specific amino acid, the basis of dietary management is to restrict the offending amino acids by means of a special low-protein diet. In addition, to meet the requirement for growth and development, it is essential to supplement the diet with the appropriate amino acid mixture, which does not contain the offending amino acid. Low-protein food products are recommended to persons with particular types of metabolic disorders such as homocystinuria, HCU, phenylketonuria, PKU, tyrosinemia, etc. Each of these disorders requires food products which are low in particular type of amino acid i.e. methionine in the case of HCU, phenylalanine in the case of PKU. However, it is not easy to find high-protein foods with low content of these amino acids. Hence, the patients are given low-protein foods, as you would realize while studying these disorders. We begin our study of these metabolic disorders with phenylketonuria. 13.3.1 Phenylketonuria. The essential amino acid phenylketonuria is utilized for tissue protein synthesis and hydroxylated to form tyrosine. The hydroxylation reaction requires phenylalanine hydroxylase. Phenylketonuria, PKU, is a group of inherited disorders of phenylalanine metabolism caused by impaired phenylalanine hydroxylase activity. PKU cannot break down phenylalanine into another amino acid, tyrosine. Phenylalanine then builds up in the bloodstream and causes brain damage. Phenylketonuria, commonly referred to as PKU, occurs at the age of 3 to 6 months and is characterized by developmental delay, microcephaly, abnormally small head, abnormal electroencephalogram, eczema, musty odor and hyperactivity. If untreated before 3 weeks of age, the metabolic imbalance produces irreversible mental retardation. The defect in metabolism in classic PKU is associated with less than 2% activity of normal phenylalanine hydroxylase. Accumulation of phenylalanine and its catabolic products leads to central nervous system damage. The extent of damage caused to the brain depends on the time at which the insult occurs. Deficient myelination and abnormalities in brain proteolipids and proteins occur in late gestation and during first 6 to 9 months of life. In the fully matured brain, the synthesis of neurotransmitters is affected. This might cause nerve degeneration, behavioral difficulties and delayed development. A precise diagnosis is necessary to establish the mode of therapy. Patients with initial blood phenylketonuria level of 121 mol/L, greater than 2 mg/Dl, should repeat the test. There are several laboratory methods to confirm the disorder. These include ion exchange chromatography for quantification of amino acid concentration, determination of genotype of parents, and assays of bioprotein and the hydropteridine reductase. Phenylketonuria can now be well controlled by special diet therapy. A low phenylalanine diet effectively controls the serum phenylalanine levels. This will help to prevent clinical symptoms and promote normal growth and development. Remember that phenylalanine is an essential amino acid and therefore cannot be totally avoided. Based on many studies, the following guidelines for dietary management of PKU are being used effectively. 1. Estimate the daily energy, protein and phenylalanine requirements, child's age and weight dependent. 2. Calculate the amount of special formula to be given to provide the recommended allowances. 3. Assess the amounts of other foods to be used. Lophenolic is a formula which is nutritionally complete except for phenylalanine. This formula is the main diet for the infants suffering from PKU. The diet should be progressed as for a normal infant and child. Utmost care should be taken while introducing new foods to them. Effort should be taken to develop a variety of recipes using foods low in phenylalanine. Phenylalanine is found in milk, cheese, eggs, fish, meat, beans, nuts, and infant formulas, both regular and soy, and to a lesser extent in cereals, vegetables and fruit. People with PKU cannot break down phenylalanine into another amino acid, tyrosine. Phenylalanine then builds up in the bloodstream and causes brain damage, as you learnt earlier. To avoid this, a person can eat a healthy diet that includes a low phenylalanine formula, fruits, vegetables, sugars and other low-protein foods. A list of foods highlighting the phenylalanine, energy and protein content of some common foods is presented in Table 13.3. Figure 13.3. also illustrates the PKU food pyramid, which can be used while counseling patients and their caretakers regarding what to eat and what not to eat. Figure 13.3, PKU food pyramid. Look at the screen. The majority of foods for a PKU patient should come from the bottom half of the pyramid. As you may have observed in figure 13.3, this contains the phenylalanine-free formula. Lophenolic in one such formula. This bottom layer provides the major food needs. The next layer of the PKU food pyramid is built of fruits and vegetables which contain low levels of phenylalanine. Eating a variety of foods, pineapple, banana, grapes, apple, cauliflower, carrots and greens, will help the patient grow strong and healthy. The next layer of the PKU food pyramid is built of low-protein foods such as breads, pasta, cereal, and rice. This layer does not contain as much food as the first two layers. Eating low-protein foods from this layer will help the patient remain healthy. The top of the pyramid is built of candies and treats. These foods should be eaten just on special days. The foods outside the target as illustrated in figure 13.4, in color red, are not included in the low phenylalanine meal plan. These are high-protein foods, such as milk, dairy products, meat, fish, chicken, eggs, beans, and nuts. These foods cause high blood phenylalanine levels for people with PKU. Dietary counseling based on the food pyramid concept illustrated in figure 13.3 and the food to target concept illustrated in figure 13.4 will be quite useful in the management of the disease. Figure 13.4, Food Target Table 13.2, Food List for PKU patients. Look at the screen. The optimal age for discontinuing the diet is not known. Phenylalanine restriction is recommended during pregnancy of the phenylketonuria women. It will be better if these women restrict the diet at the time of conception, in order to prevent the risk of mental retardation, microcephaly and congenital heart disease in infants. Some important facts related to PKU and its management are highlighted in box 13.1. Box 13.1 Important facts related to PKU. The brain of a fetus with classic PKU develops normally in intrauterine stage. The critical period of human brain growth and development extends over the first 6 months of neonatal life, requiring that dietary therapy to be instituted right after birth. Myelination may not be completed until 5 or 6 years of age, and hence dietary restriction must be rigidly followed. The proportion of dietary phenylalanine that is utilized for protein synthesis varies with age, 50 to 60% during early growth and only about 10% for normal adult. Blood phenylalanine levels must be maintained between 3 to 15 mg/dl. For a phenylalanine-restricted diet, 50 to 80% of the natural protein must be replaced by a protein preparation that contains little or no phenylalanine. Most natural proteins contain about 50 mg phenylalanine/G protein. The composition of the preparation should meet all nutrient requirements. Tyrosine must be supplemented in the diet. Usually 1/3 to 1/10 of normal phenylalanine content is recommended. Infections in the infant should be avoided to prevent tissue catabolism and increased phenylalanine levels in blood. Higher dietary phenylalanine intakes may be allowed after 6 to 10 years of age along with frequent clinical and biochemical supervision. Strict dietary restrictions should be adhered to by phenylketonuria women during pregnancy to prevent damage to the fetus. With these guidelines, we end our study of PKU. Next, we move on to tyrosinemia. 13.3.2 Tyrosinemia in the Nutritional Biochemistry course in Unit 12, subsection 12.3.3. You may recall studying about tyrosinemia. There are two forms of hereditary tyrosinemia. They are tyrosinemia type I and tyrosinemia type 2. Type I was thought to be due to a deficiency of para-hydroxyphenylpyruvic acid oxidase. But recently secondary impairment in this enzyme has been attributed to a primary defect of hepatic fumarylacetoacetate hydrolase. Patients with deficiency show renal tubular impairment, hyperphosphatemia rickets, liver failure and hypertension. The plasma concentrations of phenylalanine and tyrosine are elevated. In tyrosinemia type 2, there is a very elevated concentration of blood and urine tyrosine. Increase in urinary phenolic acids, N-acetyltyrosine and tyramine is seen. Dietary modification includes nutritional support that allows normal growth and development. Plasma phenylalanine concentration between the range of 40 and 80 millimoles and tyrosine concentration between 50 and 150 mol should be maintained. Phenylalanine, tyrosine restricted diet is advocated. Initially, a hydrolysate low in phenylalanine and tyrosine is used with small amounts of milk. If there is an elevation in methionine, a synthetic mixture without tyrosine, phenylalanine and methionine should be used. Individuals with tyrosinemia have food patterns very similar to the one for PKU discussed above. PKU is more common than tyrosinemia. Foods that are high in tyrosine and phenylalanine are high in protein. Thus, children with tyrosinemia should eat foods that are low in protein. Each child can tolerate a different amount of tyrosine/phenylalanine, so each child will have a slightly different food pattern. The most important food for a child with tyrosinemia, however, is his/her formula. Formula provides energy, calories, protein, and the vitamins and minerals, including those that are found in high-protein foods. Foods that all children with tyrosinemia should avoid are foods rich in protein i.e., meat, chicken, fish, milk, cheese, beans and legumes, peanut butter, and eggs. These foods are often called no foods and are those foods outside the target as illustrated in figure 13.4 above. Foods with moderate amounts of protein can be eaten in limited amounts. These foods include grains, bread, pasta, rice, potatoes, corn, and peas. Foods with little or no protein are the mainstay. In addition to formula, these foods include most fruits and vegetables. Low-protein products, including bread, pasta, noodles, rice etc. may also be used. Therefore, we may conclude by saying that bread, cereals, fruits and vegetables and fats are allowed. A high carbohydrate feed, providing 65 to 75% of calories, may be recommended. Next, let us review the management of maple syrup urine disease, which is yet another metabolic disorder found in children. 13.3.3 Maple syrup urine disease. Maple syrup urine disease, MSUD, is a group of inherited metabolic disorders of 3 branched-chain amino acids, BCAA, namely leucine, isoleucine and valine. These 3 amino acids are normally metabolized to ketoacids and then decarboxylated to simple acids. In MSUD disorder, an oxidative decarboxylase in the white blood cells is missing. Since the carboxyl groups cannot be removed, there is an accumulation of branched-chain ketoacids and their amino acid precursors. The branched-chain ketoacids are relatively acute neurotoxins and probably interfere with oxygen consumption and ATP production in the medullary reticular substance of the brain. There is a progressive neurologic dysfunction and production of fragrant urine with the odor of burnt sugar or maple syrup. Infants with MSUD appear normal at birth. Once they are fed on protein-containing feed, they start showing the classic symptoms. Neurologic impairment in the newborn is manifested by poor sucking, irregular respiration, and intermittent periods of rigidity and flaccidity. Clinical manifestations are expressed upon protein loading or with febrile illness. In most severely impaired enzyme deficiency, seizures, apnea, brief pause in breathing and death may occur. In untreated patients with classic MSUD who survive beyond early infancy, there is retardation of physical and mental development. Early diagnosis and therapy lead to normal growth and development. Most infants with classic MSUD have greater than 8 mg/day leucine at 72 hours of age. Diagnosis is confirmed using ion exchange chromatography to quantify plasma isoleucine, leucine, valine and alloisoleucine, and urinary branched chain keto acids. Special feeds containing energy and proteins without the branched chain amino acids can be given to the infants. In some infants, if the orogastric feeding is not acceptable, gastrostomy is initiated for initial care during the neonatal period. Long-term therapy for MSUD is by means of diet. Patients with classic MSUD are unable to terminate diet. Plasma concentration of isoleucine, leucine and valine should be maintained in the range of 40 to 90 meters mole, 80 to 200 meters mole, 200 to 425 mol, respectively. Long-term treatment of MSUD involves a carefully controlled diet which strictly limits dietary protein in order to prevent the accumulation of BCAAs in the blood. The major component of the diet is a special formula designed for children with MSUD. These MSUD formulas do not contain any leucine, isoleucine or valine but are otherwise nutritionally complete. They contain all the necessary vitamins, minerals, calories and the other amino acids needed for growth. The diet of a MSUD patient, child, should therefore involve measured quantities of natural protein or leucine from foods, a BCAA-free protein, vitamin and mineral supplement. The natural protein and vitamin/mineral supplement should ideally be evenly distributed through the day to allow maximum utilization of the amino acids for protein anabolism and for tolerance of the supplement. Free foods that are low in BCAA including sugars, fats and oils, as well as foods specifically produced for a low-protein diet, breads, biscuits, pastas etc., and supplements be given. Supplements of valine and/or isoleucine are helpful. The next metabolic disorder under review is homocystinuria. 13.3.4 Homocystinuria. Homocystinuria may result from errors of methionine metabolism. This produces defects in the function of cystathionine B synthase or 5-methyl tetrahydrofolate homocysteine methyltransferase. The most common form of homocystinuria is caused by a deficiency of the enzyme cystathionine B synthase. This enzyme is essential for the conversion of homocysteine to cystathionine. Severely impaired enzyme function produces accumulation of plasma homocysteine and methionine and decreased cysteine in cells. Large amounts of homocysteine are excreted in the urine. If this is unattended early in life, skeletal changes, dislocated lenses, intravascular thrombosis, osteoporosis and mental retardation might occur. Therapeutic dose of pyridoxine, 1 gram/day, is usually tried in all patients with hypomethionemia and homocystinemia. For patients who do not respond to pyridoxine, methionine-restricted diet supplemented with L-cysteine is used. If plasma folate concentrations are below normal, folate should be given as a supplement. What are the special preparations and foods low in or free of methionine? Table 13.4 lists some common foods and food items rich and low in methionine. This list can be referred to while planning diet plans for patients suffering from homocystinuria. While planning the diet for homocystinuria, one must consider energy, protein, methionine, cysteine, folate, vitamins B6 and B12, and fluid needs. Table 13.4 Foods and food items containing varying levels of methionine. Vegetables that are high in methionine per 100 grams, more than 50 milligrams of methionine 100 grams of the product. Vegetables that are low in methionine, per 100 grams, less than 25 milligrams, 100 grams of the product. Fruits that are medium in methionine, 25 to 50 milligrams of methionine 100 grams of the product. Fruits that are low in methionine, less than 25 milligrams of methionine 100 grams of the product. Snacks that are moderate in methionine, 25 to 50 milligrams of methionine 28 grams of the product. snacks that are high in methionine, more than 50 mg of methionine / 28 grams of the product, other foods that are high in methionine, more than 100 mg of methionine / 100 grams of the product, all pulses, green peas, corn, boiled, carrot, beetroot, boiled, tomatoes, green pepper, red pepper, yellow pepper, eggplant, green cabbage, and red cabbage, kale, boiled, lettuce, cucumber, green beans, boiled, red and brown onions, celery, okra, cauliflower, potato, spinach, mandarin oranges, watermelon, cantaloupe, honeydew melon, apples, pears, cranberries, raspberries, blueberries, strawberries, mango, plums, dates, dried, peaches, nectarines, banana, pineapple, apricots, potato chips, 28 grams, French fries 10 pieces, all nuts, like peanuts, pistachio and popcorn tofu, dried beans like kidney beans, black beans, tempeh. The discussion so far focused on the disorders linked to protein metabolism. Disorders of carbohydrate metabolism also exist. One such disorder is galactosemia, which is also an inherited disorder characterized by inability of the body to utilize galactose. Let us get to know more about this disorder. 13.3.5 Galactosemia. Galactosemia is a genetic disorder caused by deficient functioning of any of these three enzymes, namely galactokinase, galactose-1, phosphate uridyl transferase, or UDP, galactose, 4-epimerase. Galactose derived from the hydrolysis of lactose in the intestine is absorbed normally. But in the absence of Gal-1P transferase, it leads to the accumulation of galactose, galactose-1-phosphate, and galactitol in the blood and tissues. Accumulation of Gal-1P reduces the intracellular phosphate for high-energy phosphate bonds. Thus ATP, GTP and CTP are reduced. Patients with a galactokinase deficiency suffer only from cataract. Galactitol accumulates in the lens of the eye, creating an osmotic gradient that allows the glutathione from the lens to efflux. Due to this, the concentration of glutathione in the lens is decreased. Glutathione peroxidase and hydrogen peroxidase are inactivated. As a result, hydrogen peroxide accumulates in the lens, denaturing the proteins of the lens. This leads to the production of lenticular cataracts. Clinical symptoms of Gal-1P transferase deficiency is found to appear early in infancy. Some infants are born with cataract, jaundice and cirrhosis. The reason may be due to maternal ingestion of lactose. In untreated patients, development of hepatomegaly is very common. Liver is damaged, leading to decreased synthesis of prothrombin and albumin. Glomeruli and tubules of the kidney are affected due to the accumulation of galactose and its metabolites. In addition, active tubular transport is impaired because of deficient ATP. Amino aciduria occurs. Decreased albumin synthesis, proteinuria, ascites and generalized edema is seen. Without treatment, death usually results. Even if the untreated patients survive, there is retardation of physical and mental growth. Diagnosis of galactosemia is by measuring the activity of Gal-1P transferase in erythrocytes. Galactose should be restricted if the Gal-1P transferase is elevated above 2 mg/Dl. Objectives of diet therapy in galactosemia are to prevent symptoms and to provide nutrients for normal growth and development. Treatment should begin in the first few days of life itself. The goal of dietary treatment for galactosemia is to minimize galactose intake, which in turn minimizes galactose-1-phosphate production. Therefore, dietary treatment of galactosemia is to remove any foods containing galactose from the diet. Because milk and milk products are the most common food source of galactose, persons with galactosemia should avoid these foods. The diet allows most protein-containing foods other than milk and milk products. Fruits, vegetables, grains, breads, fats and sugars are acceptable, as long as they do not have ingredients that contain galactose. Some fruits and vegetables do contain small amounts of galactose. However, the form of galactose, Bound galactose, found in fruits and vegetables, is not usable by the body and may not contribute to elevated blood Gal-1P. The galactose content of some of the foods is provided as a reference in Table 13.5. Table 13.5. Galactose content of some common foods. Item galactose / 100 mg / ml cow's milk 227 human milk 350 infant formula. Soy protein isolate 1.5, casein hydrolysate 6 to 7.5, whole casein 184, aged cheddar cheese 38 to 48, fruits and vegetables less than 0.5 to 35, legumes, cooked, garbanzo beans 444, baby lima 175, kidney 153, lentil 116, soybean 44. All sources of lactose and galactose should be totally removed from the diet. Nutritional requirements for these infants and children are the same as the normal children. Foods that are excluded from the diet therefore include milk of any species. All products containing milk such as curds, cheese, ice cream, milkshake, butter, cream, milk sweets. Soups containing milk or cream. Fruits containing galactose. Any processed foods with lactose. Salad dressings containing milk. Baked products containing milk. Patient or the family members of the patients must be educated to read food labels while purchasing food. The labels of all processed foods must be read carefully for ingredients it contains. The milk products to be avoided in processed foods are milk, casein, dry milk solids, lactose, curds and whey. The milk proteins casein and caseinate must be limited in the diet. They can provide large amounts of galactose if many foods or large amounts of any food containing casein are eaten. The following products may be used because they do not contain lactose, lactate, lactic acid, lactylates and calcium compounds. Milk and milk products are the usual dietary source of calcium. Because persons with galactosemia remove milk products from their diet, they need to add calcium back into their diet through supplements. All people with galactosemia should be given a regular daily supplement of calcium. A soy-based formula can be used or tablets can be given. Fermented soy products, fermented soy sauce, miso etc. are not recommended as galactose can be released in the fermentation process. Non-fermented soy products, tofu, textured vegetable protein, and soybean extract are acceptable. We hope having gone through the discussion presented above you would now find yourself better equipped to deal with patients coming to you for dietary management of the metabolic diseases. 13.4 Let us sum up. In this unit, we studied about the nutritional management of metabolic diseases such as gout and a few inborn errors of metabolism such as phenylketonuria, tyrosinemia, MSOD, homocystinuria and galactosemia. Gout, we learnt, is a chronic disease due to an inherited abnormality of purine metabolism. Dietary treatment for gout often include a diet of lower purine intake. Drugs are so effective in lowering the serum urate concentration that rigid restriction of dietary purines is rarely necessary. Finally, in our last section, we dealt with the major diseases of inborn errors of metabolism and their nutritional management. An overview of the disorders of inborn errors of metabolism is given below. Look at the screen. Thank you for watching. We will see you in the next video with next chapter.